you need an integrated aftercare system.
Tell me more.
What that is essentially, if we really understand that we're in the recovery business and the TC approach is the one distinctive recovery approach, that from day one, even though we never used the word recovery in the early days, it all had to do with changing your life. That was a medical term, recovery. We accepted rehab and habilitation, but not recovery. That came later on. If you're recovery, that means, you're either had a lifestyle you're going to get back to, or you're going to come from a negative lifestyle and you never had a good lifestyle, and you're going to stop your drug use and you're going to change your life. So you're going to basically grow into somebody else. If you're in that business, that's the long-term business. You need, and you don't accomplish that all in one primary treatment setting, even if it's a long-term setting, like 12 to 24 months. So you need that. But then when you want them back into the world, continuing to learn about themselves while they're in the world. Not simply, I've graduated, case closed, I'm fixed. That's the wrong attitude. Every correctional client who entered a correctional TC saw that TC as a gateway to freedom. You know what I mean? They'll get out of it. Now that I finished my TC and I even graduated, I'm fixed. I don't need anything. You know what I mean? I'm going. Wrong. The right outcome at 24 months is, I see I've changed. I got it. Now I got to continue it. And what do I need to continue it? What's the help I need on that? And your clients will tell you right here. They're afraid. They don't know. They're all afraid. And that's good. That's a good thing. That's a good fear. And I learned that even in the correctional teacher. The system following the time in community is method in a therapeutic community, that system has to be really recovery oriented, with the community is method as the most effective long-term beginning of that. And then they go into essentially other settings with other kinds of, in quotes, provider issues, but they all have to be taught and trained on community is method. Not that they have to practice it, but they have to know it. And once they know it, then they know the client that they're dealing with in this. Once they know the client, you can use their particular help, their services, in a more productive way. You don't want to have dissonance, and where you have one treatment over here and then another treatment over here, a whole other approach over here. You lose a lot of benefits from that.
So as Alberta works together to develop the recovery-orientated systems of care, that integration...
That's the integration.
...of all of those different providers coming together to be responsive to one client is essential.
Yeah. And they're all on the same page about the language that they use. They can have their private histories of professional training, but they really have to recognize when you're dealing with a former substance user who's made a recovery in a community's method TC, you can really facilitate their continued recovery if you have a good knowledge of the TC and how it works and why it works. And you don't impose a whole new language system and a whole new, we're going to do transactional psychotherapy with you. You don't do that. Incidentally, even those individual therapies, they're late in that linkage process. I used to refer, and Phoenix House used to refer, long-standing graduates to certain traditional therapists, because the long-standing graduate was no longer threatened anymore with their substance use life. That was not their problem. They were now having problems like the rest of us. And that's what I would say, you came in here as a neurotic, you're leaving you came in here as a character disorder, you're leaving as a neurotic. And I expect you to be depressed and get anxious and to have problems in your life. You got to know who to be with and where to go with in order to deal with it. And if they're committed to that, they're safe in their recovery.
So, George, in therapeutic communities, we talk about them being able to support the whole person.
They came in here, their presenting problem was drug abuse. That's what they came in with. But very quickly, in those first conversations between residents, new and old residents, brand new residents and old residents, we had a classical conversation, which is, why did you come here? Because I shoot dope. And they would say, what's your problem? Well, I shoot dope. I shoot too much dope. And the older resident would say, that's not your problem. Now, as an open, it seems kind of enticing to hear it that way. That would be something like a typical early conversation. They come in, it's like if they go to methadone, they want to get some relief. They've got pain, they've got trouble, their lives are in disorder, so they come to a program. And then you ask them, why did you come to this program? They can say either I shoot dope, or even if they say my life is in disorder, I'm screwed up, I got things that, and even then they say, is that your problem? It's a tantalizing little exercise we're doing now. We want to make the point that the fact that you have all these outcomes, that your life is in disorder and you're losing your kids and you've been shooting dope, says you have a problem. Maybe the problem is you. Now that, to some purists, offends them. It never offended me. And when you do it with a good heart, we know why you came here. We know why you could be here. Simply this: if you can see that your drug abuse is a problem and it's making more problems in your life, and you're losing your jobs and kids as are outcomes of all that, can you see it's something about you that you have to change? Yeah, they may say, yeah, I just have to stop using drugs. And we say, yeah, you absolutely have to stop using drugs. Do you think that if you just stop using drugs, that'll be it? Because the usually right answer is, well, I've stopped 10 times before, 5 times before. That's the usual data. They've always said, your residents have said it, we stopped. Maybe it didn't work. Because something else has to happen. Yes, you have to stop, but you need more. So the whole person idea came out of that, which is if these individuals see that lots of things have to change, behaviors, attitudes, emotional management, values, a lot of things have to change. We can summarize all of that in terms of a number of characteristics, which I finally said for economy purposes, we'll call it we're treating the whole person. This is what we do here. All of that is going to be addressed if you'll allow it and you'll use us that way.
Thank you, George. When we talk about the future of therapeutic communities, I know we've spoken previously about the creation of Centre of Excellences. What does that mean to you?
It's a program that's runs a high fidelity community as method therapeutic community. We assess it to be high fidelity, like a top-notch hospital. It has that top-notch graduate school. This is where you go if you want to learn this. So that's my fantasy of the future. That's Center of Excellence. And so what are you top-notching? What are you really teaching? Well, we're teaching people this approach, the therapeutic. First, the setting as a therapeutic community comes out of that lineage. The particular version of it uses community as method. And you're going to need to hear all of the basic theoretical elements of that, and then the practice elements of that. You need a place where you can see it and both experience it and also hear it. That's the didactic part, and then experience it, which is nothing novel about that. That's what the great graduate schools, the great medical schools, that's what they provide. And that's what produces the higher end staff. Just picture now, if we included in that staff cadre, that training cadre, some selected professionals, psychologists and psychiatrists, which I now know since I've spent 4 decades trying to train them. But now if they went through this whole process in the way that I just described, well, we don't have that anti-intellectual bias against academic people, non-recovered people. They can be tremendously useful, tremendously powerful once they know what to do.